Good afternoon. On behalf of the Global Interdependence Center, welcome to today's executive briefing. I'm Jill Fernito, GIC's Executive Director. As a reminder to our guests, this event is being recorded and the replay will be available through the GIC website later today. Today's executive briefing is a continuation of a program series designed by the Global Interdependence Center and the Solve Long COVID initiative, entitled Long COVID Research, Policy, and Economic Impact. Throughout 2022, GIC and Solve will bring together world-class immunologists, medical experts, policymakers, and economists to explore critical insights into defining, diagnosing, and optimizing treatments and healthcare policies for long COVID and analyzing its impact on US and global labor markets. I would like to extend sincere thank you to David Kochak, our longtime friend and supporter of the GIC. In 2021, David and the Solve Long COVID initiative offered a new gift to the GIC for funding, sponsorship, and logistical support for the Long COVID program series. We thank him and Solve for their generosity and dedication to researching and understanding post-infection diseases. At this time, I'm pleased to introduce our moderator, Emily Taylor. Emily is the Vice President of Advocacy and Community Relations for Solve ME. She brings to the organization over 15 years of policy, organization, and advocacy experience in both the nonprofit and government sectors. With 5 years experience on Capitol Hill, Emily contributes a keen understanding of both state and federal policy processes while cultivating strong grassroots organization and patient representation. Prior to joining Solve ME, Emily served as the Director of Policy and Advocacy for an award-winning autism organization. There, she spearheaded major overhauls in disability, early intervention, and education policies. She is also a veteran of several successful electoral campaigns where she trained others in effective social media and online organization. She received a BA with honors in politics and international relations from Scripps College in Claremont and earned her MA in American politics from Claremont Graduate University. Emily draws inspiration from her mother, who has battled ME/CFS as well as chronic autoimmune and thyroid conditions since 1999. Welcome, Emily.
Thank you so much, Jill, for that very generous introduction. I'm so happy to be here today. Such a pleasure to bring you this next in our series of long COVID research, policy, and economic impact. Our agenda today will begin with presentations from our 4 expert speakers, followed by a quick roundtable discussion, and concluding with your questions from the audience. It's my pleasure to introduce our 4 speakers today: Dr. Peter Rowe, Megan Carmilani, Stuart Gittleman, and Trevor Gittleman. Dr. Peter Rowe is the director of the Children's Center for Chronic Fatigue Clinic and a professor of pediatrics at Johns Hopkins. He received his BA from Trinity College, the University of Toronto, and attended medical school at McMaster University in Hamilton, Ontario, Canada. He completed his residency training in pediatrics, fellowship training, and chief residency at the Johns Hopkins Hospital. Dr. Rowe is the professor of pediatrics in the Division of Adolescent and Young Adult Medicine. His clinical and research interests for the last 25 years have focused on medical conditions characterized by chronic fatigue. His work has emphasized by the importance of a variety of psychiatric risk factors in chronic fatigue syndrome, including circulatory dysfunction, joint laxity, allergic inflammation, and adverse biomechanical strain. He has directed the Chronic Fatigue Syndrome Clinic at Johns Hopkins Children's Center since 1996, where he is the inaugural recipient of the Sunshine Natural Wellbeing Foundation Chair in Chronic Fatigue and Related Disorders. Next, joining us is Megan Carmilani, the founder of Long COVID Families. She's a disability advocate with decades of experience fighting for awareness and healthcare for the disabled. Diagnosed with the post-viral syndrome as a child, her lived experience and disabled teen, adult, and parent is what drives her work. She created Long COVID Families to give children and caregivers support and guidance with a focus on self-determination, empowerment, and equity. She incorporates the acquired skill set of living with ME, POTS, MCAS, which is mast cell activation syndrome, fibromyalgia, and other chronic conditions into her work, her parenting, and her advocacy. Megan has her MED in curriculum and instruction and is a former reading specialist and a mom to Anna and a partner to Andrew. Last but most certainly not least, we have Stuart and Trevor Gittleman. Stuart was a CEO at Advanced Care Incorporated, which he owned with his wife, Nancy, for 25 years. At the time of its sale, ACI was the largest independently owned acute care home infusions provider in the New York State. Stewart is a small business entrepreneur with a great deal of experience managing and developing clinical sales talent, clinical and administrative personnel, and problem solving regarding the strategic business concerns. Stewart and Trevor live in New York. Stewart's wife, Nancy, has been there since 2000. Stewart and his wife, Nancy, have been there since 2016. Their two children are 28 and 29 of age, one of which is Trevor. Trevor is an investor, a musician, and an 18-year sufferer of myalgic encephalomyelitis, which is related to long COVID with a different origin. He's 29 years old and lives in Brooklyn, New York. Thank you, all of you, for being here today. We'll begin with this session with the quick presentation from Dr. Rowe. Dr. Rowe, the floor is yours.
Okay, great. Thank you very much, Emily. Let me start with the overview of what I want to cover today. Just very briefly, we've been looking, as Emily said, at the physical contributors to ME/CFS. And so when the COVID pandemic began, we thought this may very well be another of the infectious causes of the same group of symptoms as ME/CFS. And briefly, it certainly appears that way thus far with the data that we've gathered and the experience we've had here at Johns Hopkins, and I think that's mirrored around the world. A brief comment about the epidemiology. We are still gathering data on this, but one of the best sources of information about who gets this and how commonly comes from the Office for National Statistics in the UK, where they have surveyed over 273,000 households looking for prolonged symptoms after COVID. And this is really the money slide from their reports. This is data collected in the 4 weeks before December 2021, so well into the pandemic. And this slide shows a very similar pattern in the epidemiology of prolonged symptoms after COVID to what we see in pediatric ME/CFS. And that is that it's very uncommon, not unheard of, but much less common to see this under the age of 10 or 11. And so at 12 weeks, and then in the blue 12 months, this is the proportion of children under 12 who get symptoms. You start seeing more of ME/CFS, and now it appears long COVID after you get to the early part of adolescence. And by the 17 to 24-year age range, you are starting to approximate the rates of disease that you see in adults. Notice that while some have argued that 30% of patients will go on to get long COVID, and you see different things in the popular press, these data look very different, and much depends on how many months you count as long COVID and also on the frequency and severity. But at the 12-month point, the 17 to 24-year-olds in the UK, 1 in 200 goes on to get substantial impairment. Keeping in mind that the UK has about a fifth of the population of the United States, at least for the US population, their data would extrapolate towards about over 250,000 as a minimum estimate for long COVID. It's really important to remember that how we define long COVID has major implications for how we count it, but also for access to treatment. And there are a number of definitions of long COVID out there. The CDC, in having a broad attempt to corral these symptoms, said anything beyond 1 month counts as post-COVID conditions. The WHO suggested 3 months, but there's an argument you could make for focusing on the frequency and severity of the symptoms and on the duration that's similar to long COVID. And I wanted to just give an example about how you make the diagnosis and what the implications are in other post-infectious illnesses, in this case from mononucleosis. And this is data from Ben Katz's group in Chicago showing that if we estimate the proportion who have fatigue at the onset of mono, it's about 100%. By 6 months, 13% meet criteria for ME/CFS. So if you build your clinics around the notion that the illness really gains traction at 3 months, noticed that 37% of this overall population would get better spontaneously between 3 and 6 months if they were jostling for space in post-COVID clinics. They would elbow out the 13% who are going to go on to need clinical care. So one of the dilemmas that we face and one of the challenges is we've got a very poor infrastructure for long COVID and ME/CFS clinics, and we have to be judicious and thoughtful about what we define as serious enough to warrant care, and trying to triage those who are going to get better spontaneously to their primary care providers, not the specialty clinics. This is not to say that everybody doesn't deserve care. Everybody does from the beginning, not just from 3 or 6 months, but there are big implications for the availability of clinics. We've been impressed that the adolescent and young adult patients we see who have confirmed or probable COVID-19 who still have symptoms at 6 months have been meeting the criteria for ME/CFS. As in the previous slide, there's some peculiarities about mono, for example. More people have splenomegaly and sore throat in the beginning, but by the 6-month point, those symptoms that are individual to mono have disappeared, and what they're left with is ME/CFS. And it's the same with long COVID. Changes in taste and smell tend to cluster in the first couple of months of the illness, and by the time they're impaired at 6 months, they really meet the similar criteria for ME/CFS. Many of the lessons we've learned about what to look for and what is treatable in ME/CFS also apply in long COVID. So here's an example of a freshman at Johns Hopkins who was on the cross-country team before he got sick. He was able to run 60 to 70 miles a week. He got COVID, and within 2 months immediately after COVID, he was lightheaded and had tachycardia, fast heart rate. And 2 months after the illness, all he was able to manage was about 15 minutes of a very moderate paced walk twice a day with his parents. When we brought him in and tested him for postural tachycardia syndrome, he had this extraordinary rise in heart rate from 59 beats per minute to 129 beats per minute. So he more than doubled his heart rate, and that was capable of provoking his symptoms. He is still not back to baseline 2 years after the onset of COVID, although the lessons that we've learned from treating ME/CFS have been applied to him, and he's certainly doing better as a result of that work. And it's going to be very important for physicians who run the long COVID clinics not to lose sight of the lessons we've learned over the last few years. One of them is that many of the patients we've seen and reported have a lot of allergic and inflammatory manifestations. So the first patient whose standing test you saw has allergies to foods, including cashews, carrots, and cherries. He gets oral swelling. The second patient has a lot of allergic inflammation, including hives with citrus fruits. The third one has the ability to write on her skin, dermatographism, facial flushing, and a very positive family history. 2 of them had elevations in their histamine levels. And we learned to look more carefully for this based on our own experience with ME/CFS in patients with milk protein intolerance, but also pioneering work by Larry Afrin, a hematologist who has hypothesized that the acute disease with bad disease with the lungs in COVID is hyperinflammation that's driven by the mast cells, and that the mast cell activation may be part of the post-COVID illness. And there's some evidence emerging that treatment with the drugs that are used for mast cell activation can be helpful in long COVID. That's all preliminary, but it's interesting. Other work by Dutch colleagues, Linda Van Kampen and Frans Visser, has shown a very similar range of symptoms if you look at patients with long COVID and those with established ME/CFS. This is just one slide from a recent paper of theirs. They have a really interesting technique of measuring brain blood flow by putting a Doppler ultrasound probe on each internal carotid and each vertebral artery. And they add those 4 vessels up to get total cerebral blood inflow. And at the bottom, you see on the left, the carotid artery flow here showing with systole, you get a big increase in flow. When that patient has been upright for 30 minutes, they get an 8% reduction in brain blood flow compared to supine. At the top, you see somebody with long COVID who's had a 39% reduction in brain blood flow. I defy you to think clearly, find words, and not be fatigued if you've got that degree of substantial cerebral blood flow reduction. So that was a single patient. But when you look at the whole group, they had healthy controls. They had 10 with long COVID who all met ME/CFS criteria and had POTS. And they had two groups of 20 that they'd studied previously in the same manner, one with ME/CFS and POTS and the other who had a normal heart rate and blood pressure response to 30 minutes upright. And you can see that the long COVID patients were doing worse. Some people in the field will say that, well, the reason people have orthostatic intolerance when they've been sick for 7 years is that they are deconditioned, in which case you'd expect this group in red or this group in yellow to have the worst cerebral blood flow, but it was the ones who had the least illness. So it's clear that COVID is doing something profound to interfere with blood flow to the brain, and we need to look at how to treat that. One last point is that we need to remember that in all studies that have looked at pediatric quality of life in ME/CFS, those who have ME/CFS have much worse function than many of the other chronic illnesses that we see, including sickle cell disease, diabetes, eosinophilic gastroenteritis, and cystic fibrosis. I think this slide always surprises my colleagues in pediatrics, that the ME/CFS patients do worse than all of these other chronic illness patients. But this means that we have got to expand our capacity for treating those who had pre-pandemic ME/CFS and for those who have long COVID during the pandemic period. They look like they are one and the same. We ought to harness the energy and the enthusiasm for addressing long COVID and make sure that we address those who have had this illness before. I'll just end with two resources, one written by a group of us. Amanda Morrow and Laura Malone run the long COVID pediatric clinic here at Hopkins. Christina Cocorellis runs the pediatric POTS clinic, and others are either patients or investigators in this field. This is a fairly lengthy review. And there's also the ME/CFS primer for those who are looking for information on guiding therapy. So I'm going to stop there and let Emily move things forward.
Thank you so much, Dr. Rowe. That was so insightful and really helpful to understand kind of the medical basis and the state of the science and where we are now. Next, we'll hear from Megan Carmilani, founder of Long COVID Families. Welcome, Megan. The floor is yours.
Thank you. So I have a lot of information I want to cover. So in an effort to be efficient, I just wrote it down. So let me grab that. So my name is Megan Carmilani. I am the founder and president of Long COVID Families. We are a nonprofit that supports children and caregivers with long COVID. I am here today to talk to you about impediments to care specific to the pediatric community. I do not have long COVID myself. However, I do have post-viral syndromes that are anchored in an infection I had as a child, leaving me with symptoms almost identical to many children with long COVID, symptoms I still have today. It took me almost 30 years to receive an appropriate diagnosis and medical care. I do not want that for any other child, which is why I'm here today. Unfortunately, the barriers to medical care I experienced as a child are still present. Long COVID is an invisible illness for the most part. Standard medical tests do not tell us much. Therefore, the primary source of information is the patient themselves. This means the patient's ability to articulate the internal workings of their body is essential for treatment. This puts children at a disadvantage as they typically do not have the language of illness, or they are pre-verbal, and some are nonverbal. They usually do not know how to interpret these strange new body sensations. For example, I was first diagnosed with mono when I was 11, after which I had a sensation in my chest that I struggled to describe. I repeatedly told adults I can't breathe, and I was told it was anxiety. So I stopped telling anyone what I was experiencing. I continued to have that sensation in my chest to this very day. Turns out that sensation is tachycardia, which I learned when I was 39. Kids with long COVID often describe tachycardia in the same way. They will say, I can't breathe. Other things kids have said, my throat hurts, when they mean their necks. They'll say, I can't think, when describing cognitive dysfunction, or sometimes they'll say their head hurts when they mean they're struggling to process new information. One of the hallmark symptoms of post-viral illness, including long COVID, is fatigue, which is also one of the hardest symptoms to identify in vocabulary. They might say they're tired or they don't want to do something. It can be as confusing to the child as the parent. And typically it's contributed to lifestyle, such as sleep or diet. In addition, children struggle to communicate the impact of fatigue on their daily lives. This is because they lack the lived experience to have a clear sense of before and after, which is what many adults rely on to explain debilitating fatigue. For instance, you may hear an adult say, I used to be able to work a 12-hour shift, and now I struggle going to the grocery store. What's interesting is that we've noticed that athletes seem to be diagnosed quicker than the average child. And that may be because the symptoms are easier to identify. As one teenager said, I used to run the stairs at school, and now I can't even walk 3 steps without feeling like I need to sit down. So there's a clear before and after that can be observed by adults. The observation of symptoms by adults is vital when it comes to recognizing long COVID in kids. They need an adult to truly see their struggle. If that doesn't happen, then that is an insurmountable obstacle to medical care. Kids can't take themselves to the doctor. It will often take a caregiver more than 6 months, often 9 months, to recognize long COVID. Sometimes it's taken more than a year, which begs the question, how many kids are we missing? Once a caregiver recognizes the symptoms, there's yet another obstacle. The caregiver has to explain it to the doctor in a way the doctor can receive. Parents will often say things like, my child is just not behaving like himself, or my child spends all her time in her room. This is not enough information in a 15-minute office visit for the doctor to figure out it's long COVID. Additionally, even if the parent clearly explains the child's symptoms, diagnosis still requires the doctor to be knowledgeable enough about long COVID and post-viral illness to recognize the pattern of symptoms to inform proper course of action. I want to go back to my story for a moment to demonstrate how easily these symptoms can be missed. Again, I was 11 when I was diagnosed with mono. Months later, I noticed I couldn't run as fast in soccer, and I often felt lightheaded and dizzy. I was told I was dehydrated. I would nap after every game. I was told that was because I was growing. Soon after, I quit soccer, unable to keep up with my peers. My parents thought I had just lost interest. I now know those were symptoms of POTS, which is a dysfunction of the autonomic nervous system, and post-exertion malaise, one of the hallmarks of ME. I had serious digestive issues. I was told IBS and hormones were to blame. At 39, those symptoms finally resolved after I started taking medication used for mast cell activation syndrome. I had pain in my legs. I was told that was due to growing pains. I now know this is a common way for kids to express fatigue or even blood pooling in the legs, which is a symptom of POTS caused by blood vessels not constricting properly. So you can see how easy it is to miss these significant symptoms. As a child, I had no other choice but to push through. I progressively got worse over the years. By the time I was in my 30s, I was no longer able to work, and I spent 3 years essentially bedbound. Countless doctors were unable to help until I met one who had a significantly different approach. More tests were run, and once again, results were within normal range. I expected the doctor to say there was nothing else we can do, as all the others had. Instead, this doctor pulled up a chair and asked me a series of questions. When, where, how do you experience your symptoms? There was something in my answer that made her eyes light up. She grabbed a piece of paper, wrote down instructions for me to record my blood pressure and my heart rate. She handed me the paper, told me to buy a blood pressure cuff, and come back in a week with my heart rate and blood pressure numbers. Without fully explaining, she was directing me to do what is known as the NASA 10-minute lean test. A week later, I brought my numbers in. They were all over the place. She looked over the paper and announced, "Well, it looks like you have POTS," which was a medical condition I had never heard of. I was then referred to a dysautonomia clinic for further testing and encountered another doctor with a unique approach. After the doctor introduced himself to me, he took out a pad of paper and he said, "Tell me about your symptoms. Start with the first time you noticed them or that something was off." And then he listened intently as I told my story, beginning when I was 11. He asked me questions in an effort to identify a pattern. Within the week, I had multiple new diagnoses, new symptom management strategies, and medication. Within a month, I was able to get out of bed most days. It was like someone flipped a switch. That was only 4 years ago. I am still disabled, but treatment took away my suffering. I take the lessons I learned from those two doctors and I share it with the caregivers today. The context of the symptoms matter, the frequency, the severity, and duration. In order to capture this information, I suggest that caregivers develop scientific observational skills, which is to observe using the 5 senses and document those observations. For instance, what do you see when you look at your child's skin? What do you see when you observe them doing homework or eating, when they are sitting, standing, walking, climbing stairs? What do you notice about your child's sense of sight, sense of smell, sense of taste? I suggest caregivers document these observations over the course of 3 weeks and bring these observations to the doctor. And for parents who have tried this, it's been a very successful strategy. So that's what we can do as caregivers to help children with long COVID. We can truly see them. What pediatricians can do is to understand that long COVID in kids typically shows up as syndromes, which means the pattern of symptoms is important. It's also important for the doctor to look at co-occurring symptoms and to know symptoms are typically waning and reoccurring. We need doctors who are familiar with common comorbid post-viral syndromes and are able to identify the evidence of illness in a patient's story. In addition, we need doctors to be open to noticing new patterns that might be unique to long COVID. And finally, we are seeing organ damage in some children post-COVID that is not apparent on standard testing. For instance, some of our children have lung damage that only showed up on SPECT imaging. All of these children were initially told that they had exercise-induced asthma, and it took more than a year of reporting symptoms for lung damage to be found. We have also heard reports in our patient forum of liver, heart, and kidney damage. I have no way of knowing how often this happens or if COVID is fully or partially to blame. I simply know it's happening, and we need to look into it. Thank you for your time.
Again, and thank you for sharing that that journey you've been on and giving back to others. Your organization does so much to help so many. We're so grateful. Thank you so much. And next we'll hear from Stuart and Trevor to share your story about going through this as a family.
Megan, Dr. Rowe, what a wonderful lead up to us. I almost don't have anything to say. I mean, that was phenomenal. I'm privileged and proud to be part of this call to action. Before I go forward, I would like to suggest that our viewers, if they have an opportunity, well, if they don't make an opportunity, go on to solveme.org and look at the white paper that we have there for more information. Part of that white paper, one of the most stunning pieces of information there is that there are 7 million people as of January who are suffering from a disabling version of long COVID. That's a stunning number. It's about 2% of the population. We need to pay attention to this, and shame on us as a society that for 30 some odd years, Megan has had to go through this hell that she's gone through with virtually the entire medical community not paying attention to this disorder. Comedians, you'll find them still on YouTube making fun of chronic fatigue syndrome as being a non-real disorder, and doctors doing the same. This has been a frustrating, terrifying, and agonizing 20 years with my son Trevor. Having a child with a disability, any disability, is difficult, but a disability caused by a disease that doctors know little about, can't fully treat or cure, and that many don't even recognize as a real illness, presents its own unique challenges. Lots of false promises and false hopes have entered our lives these past 20 years. The positive about this journey is that I couldn't be prouder of my son and the courage he has demonstrated, but particularly his unrelenting spirit of appreciating whatever positives life has to offer. Trevor blocks out many memories of his journey, and we've discussed this before this presentation, both due to his brain fog and the pain that these memories cause. He's often said that in this respect, his brain fog is a gift. He subconsciously forgets what he's missed out on throughout his life and what he has experienced all these years. So Trevor has asked me to help him cover today as much as he can in 5 or 10 minutes. Let's just start right off with the basic question, Trev. Apparently, you and Megan are kindred spirits. You seem to have had the same start to chronic fatigue syndrome.
It's really true, Dad. Just starting for me, I was a normal kid. I was a normal kid until I was about 10 years old. I was extroverted. I was active. I played baseball. I was on the all-star team. I pitched. I was even president of my class. I was full of life. I was in the gifted program. Everything was sorted for me until I got mono in the end of that 5th grade year, and I missed a month of school, which is really odd, but because nothing had ever gone wrong like that in my life. And I thought I would just bounce back, because you always think you bounce back as a kid, you're invincible. I had a normal-ish summer. And then in October of that year, I went on a bike ride with my dad, and going up a hill, I felt my heart just pounding in my head and my vision narrowing, a black tunnel. And I woke up on the ground, and my dad said looked like I had a seizure or something. We went to the hospital because I couldn't shake the dizziness. And they tried to give me fluids. They had no idea. I tested, everything was normal, but I couldn't walk. I was so tired. I had constant headaches. There was something wrong with my gut. I couldn't eat foods I could usually eat. I couldn't eat dairy all of a sudden. I couldn't eat. I was bloated. I was just, and most importantly, I could not think straight. I spent all of middle school in a wheelchair or in bed. I would crawl around as a preteen to go from place to place in the house, sometimes even being carried. I was that weak, and I had no explanation for it. I had so little explanation for it, and yet my parents, that I can never express enough thanks for, were in the medical field and completely believed me, because there were doctors. There were doctors who gaslit me. There was one doctor who gave me a UTI medication that turns your urine orange and told me if it turns your urine orange, you'll be cured. Thought it was completely in my head. I took it, of course, nothing happened. This kind of thing is the hubris of the medical community that everyone who's had this for a long time has experienced. There's no recognition of how invisible this can be. And something Megan mentioned that I really appreciate is the waxing and waning of it, is that I had those terrible years in middle school. I got well enough to experience high school. I was sick a lot, but I experienced high school. And then, of course, I got sick again, because that's just the way this disease works. It comes and it goes. And sometimes doctors would give me a new medication, and this has continuously happened for 20 years. They give me a new medication and it helps for a few months or sometimes just a few weeks. And then my body finds a new way to just be completely exhausted again. The number of diagnoses that I've had, I just ME/CFS, chronic Lyme disease, postural orthostatic tachycardia, central sleep apnea, narcolepsy, mold poisoning. They've called it so many different things. I think dysautonomia covers it well, but my body fundamentally doesn't regulate itself the way that it's supposed to.
Trevor, how did it affect your social life and growing up as a young child?
That's the one that hurts. I managed to not say that. So I had a lot of friends in 5th grade, and in 6th grade, when I was missing, the school put together a poster like they would for a kid who has cancer in the hospital, and everyone signed it, and some people sent pictures, and it was trying to be my friend and trying to reach out and get better soon, get well soon, that pithy thing, and it was sweet, and I still have that poster. But when I went back to school, I wasn't allowed to sit back at the same table. So I was the weird kid who was never there. And that hurt. And that changed my life. I was the outcast. I went from I won a popularity contest in 5th grade. I'll never win one again. I completely recoursed my relationship to other people, and as unfathomable as it is, spending time imprisoned in your house, interacting with no peers for months and months on end, sometimes not going outside for weeks. As a child, your social skills take a hit. I felt autistic. I am not, but when I would interact with people, I would talk too much. I would over-engage. I would overcompensate, and I'd be on various stimulants to function, so it would make it worse. It was the most humiliating, embarrassing process. And on top of all that, growing up and becoming a man, the last thing you want to do is show weakness. The last thing you want to do when you meet new people is say, I'm really tired and unreliable. It makes dating difficult. It makes meeting new people difficult. It makes showing up for anything. They know that they'll invite, you're making a new friend. The number one thing you have to be is consistent. And that is the last thing that you can be when you have chronic fatigue, when you have ME.
How would it change things for you if long COVID or ME/CFS was a recognized disease like the cancer is?
It would be unbelievable. I would feel comfortable saying it. It's only after 20 years, only in the last 2 years have I been public about even having it. I've hit it. I was afraid to invite even friends I've had for years to this talk because I knew that their understanding of it wasn't as deep as I was going to go right now. That their understanding of it is not complete. If I were able to say that I had cancer, I know that people would be there because they know what it is, because it has a public face. We need to be that public face. And that's why I'm really glad to get to share my story here today.
Yeah, we call this disease the invisible disease because patients feel invisible. And when they walk into a doctor's office, they feel invisible. When they're with their friends, they feel invisible. And they're embarrassed to even tell people what they have, and they try and hide it or just don't show up. Is that right, Trev?
Yeah, it's
How did it affect your academic life going forward and your dreams?
it made graduating take years longer than it should have. It made my aspirations as a musician impossible.
Why? Why?
You got to be there. You got to show up. You got to be on your feet. You got to travel. You got to tour. You have to be consistent. And I will only feel well at intervals. And the way I used to do it is I would just plan a show at short notice when I knew I was feeling well enough to do one show. I haven't done a show in 5 years, but that was what I wanted to be. That was what I went to college for originally, and I wanted to be a musician. And it's a dream killer. And I think that graph that Dr. Rowe showed of the quality of life is the most important chart. Is that we have it harder than well-recognized diseases in terms of how much life we can actually experience, what we can build with our lives.
I'll never forget about 2 months ago, Trevor, you had an unbelievable, as you said earlier, it waxes and wanes. You have good days and bad days. You had a good 6-week run. And sometimes the disease, ME/CFS or long COVID, it goes away by itself. You know, not everybody gets it forever, but many people do. And you were excited that it was gone. You had this, remember the movie Awakenings, an Awakenings moment. And we were sitting in the park. We went walking for 4 miles, which was unprecedented. We did it the following day, another 4 miles. We went out to eat. You didn't have any stomach issues. We shopping. We talked about the childhood that we both lost out on, and we cried, and we started to dream again about what you were going to do with your life going forward, and it came back, right, Trev?
That's right. It came back. I'm in a harder time now again, and I'm still pushing myself to get outside and do what I can still do, but yeah, there's an immense loss. And the big way that I've coped with it, in a big way that I'm usually able to do these talks, is that I dissociate, is that I don't identify with myself as a way of protecting myself. And that's something that kids are doing. They will become, there's no way you can do it without it. They become numb. You become numb to the fact that you're not living your life. You're a shell. You're an absolute shell of yourself. And the hardest part of it is the waxing and waning, is that you get the hope and you lose it. You get it taken away. I compare it to Flowers for Algernon. It's just this ride into the beautiful, visceral, nuanced reality that is life, and then having it ripped away.
I think we can end on that note.
Yeah, I think so too.
Thank you so much, and Trevor and Stuart, for sharing that family journey that you've gone through with this illness. The first question actually comes from the audience to get us started in our conversation regarding the realities of life with post-viral illnesses. And what are post-viral illnesses? We've talked about a lot of different acronyms that are associated with that family of post-infection diseases. Dr. Rowe or Megan, would you like to talk a little bit about what the family of illnesses we see under that post-infection illness category, including long COVID?
The biggest
Sure.
one. Yeah,
Go ahead if you want to talk about it first.
no, go ahead.
Oh, I was going to say, I can speak to it because I think I have all of them at this point. So first off, there's syndromes. So they're a collection of symptoms. And so they often overlap with each other. But primarily what I have and then what we're seeing in kids in long COVID is, as Dr. Rowe was speaking earlier, a significant portion of them seem to meet the criteria for ME. However, we do not have very many doctors that know about ME. So what they're typically getting diagnosed with, though, is POTS, which is postural orthostatic tachycardia syndrome. Some are getting diagnosed with MCAS, which is mast cell activation syndrome. And we will also see a lot of pain diagnoses, a lot of fibromyalgia. And I think it's usually the first diagnosis a kid will get, because I think pain is what they can express. I bring that up now because what we find, though, is that if they go on mast cell stabilizers, the fibromyalgia often resolves. So is it truly fibromyalgia, or was it MCAS that was causing the inflammation and the pain? All the symptoms, they often go together. One triggers another. And so if you have a child that has one syndrome, it might be a good idea to look for the other syndromes. For me, I was initially diagnosed with POTS and then MCAS. When I couldn't take POTS medication because it kept dropping my heart rate too low. It just so happened that I went on all this MCAS medication. It stabilized my POTS enough that I got, I was able to get out of bed. And so that was an interesting thing, because they're all related. And so my doctors at least have told me they think in my case, that's the mast cells triggering the dysautonomia.
I think that's a great point, Megan, that you're always looking as a physician for what's the driving force for each patient. And for some, it's an allergic reaction to milk protein. We see that in 31% of our ME/CFS patients, which is a huge proportion. A subset of them have the MCAS, and it's really important to look for that. The other point I would make, Emily, is that, people often talk about POTS as the only form of orthostatic tolerance. It really isn't. And in the adult studies from the Netherlands, 60% of their adults have a normal heart rate and blood pressure response to upright posture, yet they still have severe reductions in brain blood flow. So I think over time, we're going to be redefining how we classify these disorders with direct measurements of brain blood flow, not focusing on heart rate and blood pressure so much, because those who have a normal heart rate and blood pressure response, but lots of orthostatic symptoms, are really about as impaired as anyone with POTS or hypotension or these other conditions. The other thing we've found it very helpful to look for, and this has been for the last almost 25 years now, is that our patients with ME/CFS and long COVID are much more likely to be flexible, to be hypermobile. They have 60% of them are very, very flexible compared to 24% of healthy patients. And so these are dancers and gymnasts and swimmers and cheerleaders. They have a skill at those things because they're flexible, but it puts them at risk for orthostatic intolerance and for many of these other comorbid conditions. It's really key to look for that.
Thank you so much. Another question that we talked about as we were planning for this call is what is the one key takeaway? And I'd love each of the panelists to answer this. What is the one key takeaway that you would highlight that's the biggest difference between these post-infection illnesses in adults as opposed to children? And what sort of, you could do one takeaway for the pediatric population or the young adult population, what would be that one takeaway? Trevor, I'm going to pick on you first, if you don't mind. What would you like to share with folks about that difference between doing this journey as an adult versus doing this journey as a child?
Well, when you do it as a kid, you have no idea what life's even supposed to be. You hear people describing long COVID as, oh, I can no longer run marathons. I can no longer, keep up with, I don't know, my wife on vacation or something, things like that. It's
or
not
your job,
that. Or your job.
Of
course, your job, or or your social life that you've built over your life, over time, cumulatively. But if you start your life and you don't know what life is supposed to be, it just, the foundation is destroyed. So that's the difference. And of course, you're a little guy, so hopefully someone believes Chicken Little, is you're saying, oh, you don't want to go to school. Yeah, I don't want to, I'm not getting out of bed, Mom. So yeah, I think that's the takeaway, is it's completely different. Even though it happens less often, it's far more devastating to a life.
Stuart, as a father, what did that journey, what was that biggest difference for you as an adult looking at your son going through this journey?
Frankly, back when Trevor started having it, it was worse than now. We have this pandemic that has brought attention to the disease, and you can actually find doctors, wonderful doctors like Dr. Rowe, who know about it. Back then, we were just being told we don't know what's wrong, and so we just cried. We thought he was dying. So it's and I want to also mention that we have, fortunately, resources to pay out of pocket, when insurance doesn't cover things. This disease hits everybody. It hits minorities who don't have the resources. I just don't know how people can deal with this disease, needing income, needing medical care, and not having independent resources, because the system isn't set up for this.
And Megan, as a expert in those systems of care and those barriers to those systems of care more specifically, how would you add, what's the one takeaway you would give to families who are looking at young children going through this journey, and what would be your takeaway?
So barriers I experienced personally is we don't believe children, right? We do not trust them to be authorities on their own body. They don't have autonomy, right? And it's a cultural thing of, it's how I was raised, and I'm sure it's how my parents were raised, of toughen up, get out of bed, keep it going, push through, kind of a thing. And so sometimes I feel like the American culture itself is a barrier. I know I've expressed to people that sometimes it feels, to have these conditions feels un-American, right? And that rugged individualism is not something that would ever be applied to me, right? And so you feel like you're bumping up against the culture at all times. The other thing is, I was not believed, and it was scary because they immediately went to, you must be mentally ill. And then the power dynamics that come in, and the hovering, like, almost sense of I could potentially lose my freedom if a doctor stepped in and said, we think you need to be hospitalized. Like, there was that kind of, and there's a lot of patients, and I think that just kind of hovers in the back of your head in our community. It's interesting that the older I got, the more doctors were willing to believe me and take me seriously. And there's a bit of a stereotype that these kinds of conditions happen to middle-aged women, right? And so I hit another set of barriers of, like, well, you're, middle-aged and you're stressed and you're, and it was a different stereotype. So there was that. I would say, though, one of the, I've experienced personally, and I'm seeing it in long COVID community, what I don't think the public fully appreciates, is that these conditions are a direct threat to your survival. So if you do not have a family who has resources, your food and shelter and ability to survive is constantly threatened.
The suicide rate is very high.
Well, yeah.
6 times the general population.
But it's to have that as a child. Like, I have never fully had the ability. So in my 20s, I didn't have a diagnosis, and I kept trying to work, and I would go through cycles of being able to work and then crash, and then be able to work and then crash. And I was just barely making it. And certainly not making it on my own. But I don't think people fully understand, like, what scares me the most about these children coming up with long COVID is, for the rest of their life, potentially, if we don't get them identified, diagnosed, and proper medical care, they will be struggling just to survive. And I think the other thing the public doesn't fully understand is that this is a trauma when you get an acquired illness like this. This is a trauma for these children. This is too much, too fast, and they don't have the ability to comprehend what is happening. Their family doesn't have the ability to comprehend what is happening. I mean, they don't understand what's going on inside their body. They don't understand why people are reacting to them the way they're reacting to them. So you've got the trauma coming from in, you've got the trauma coming from out. You've been pushed out of society. You have the direct threat to your survival needs. It is one of the most complex traumas a human being can go through. And there's no resources right now. Where do we send them? There are no qualified healthcare providers for mental health that have any understanding of what this is. And so even people who go to mental health providers end up quitting because they're saying, Megan, they don't get it. I can't just change my thoughts and it's all going to be okay. That's not going to feed me. And that's something I don't think the American public even understands. And I'm worried for these kids.
Absolutely, and as are we all, which is why we're having this conversation to help raise awareness of this critical issue today. So we have about 5 minutes left, and I'd like to touch on the very last question that we had prepared was really about the intangible impacts on young people fighting long COVID and other post-infection illnesses. Trevor really shared about what that did with his journey, but I'd like to have each of you share a little bit about what we collectively can do as loved ones, as members of society, as medical care providers. What is one piece of advice you'd have for the rest of the world dealing with long COVID or looking at long COVID to help the people who are experiencing this and to help young people on their journey? What's one piece of advice that you, or maybe one experience you'd like to share that was a positive that really helped, and we can hopefully get the message out to share that positivity? Trevor, is it okay if I pick on you again first?
You're not picking on me. It's what we're here to do. It's what we're here to do. What piece of advice would I give to kids and families? To kids, it's okay not to be okay. That's what I then that got me. Yeah, that's the thing. That's the thing, is you have to not suck it up. Like what Megan said about the American personality, the Protestant work ethic, that whole thing is like, you know, bootstrap it and all that stuff, just not apply to everyone. And it's okay to be a part of something, to contribute what you can, to do kinds of work that don't necessarily have due dates. They're just assignment based, and you know, the asymmetrical learning, you know, you can learn over different periods of time. You can take more years to achieve things other people achieve. Life doesn't happen on the same timeline for everyone, and that's okay. It's that self-love is very hard to learn, but if it's instilled early, they won't feel this guilt and shame of not arriving on time.
I love that's a beautiful sentiment, Trevor. Thank you. And Dr. Rowe, I'm sorry, I cut you off earlier. Would you like to continue?
Well, I just remember one of the things that one of the families said, and Trevor put it so nicely, that a large part of, you know, friendship and socialization is being consistent and being able to show up. And one of the things we learned from our patients is they are so reluctant to cancel plans at the last minute that they stop making those plans. And so it becomes a very isolating illness if they're really impaired. And one of the families just did something really cool for their sons who both had this. And that was, they just decided, all right, we're going to make the coolest basement that we can, you know, with video games and TVs, so that people come over here to hang out. You know, not everybody has those resources, but that was a really neat thing that helped these two boys remain engaged with their community.
Thank you. It's a beautiful sentiment as well, to bring community in instead of pushing outwards to join community. I love that. Megan or Stuart, do you have anything you wanted to add? Some final recommendations?
Sure. I mean, I would echo the need for community. There is a vibrant post-viral community online. There really is. And I've met some of my best friends just online in various groups and various communities. So I would look for that. Also, I would say one of the things that I have found really important is to understand my body. And so to really take the time, especially when they're young, to teach them what's going on. You know, it's terrifying to get tachycardia and not know what it is and why it's happening. I mean, it's terrifying. But as soon as somebody knows this is what it is, and that it's your heart trying to get blood to your brain, right? Like the heart's trying to help you out. And that's very calming for kids to like understand what is going on with their bodies. The other thing we help explain to children is that symptoms are your body's way of communicating. And so a lot of times we'll teach like and share the strategy with children of like, I get tachycardia, my body's telling me it's having a hard time getting blood to my brain. So what could I do to care for my body? And it could be drinking electrolytes, it could be going to lay down, it could be compression socks. But it's kind of a helpful tip for kids to say, my body's signaling it needs help. And so I can help my body by doing. And if they understand what's going on with their body, it takes away some of the fear, right? That can be triggered, especially in younger kids. And so I would recommend that too.
Thank you so much, Megan. And Stuart, you'll get the final word. Any final thoughts you'd like to share to other parents out there that are struggling with this journey, or other families that are looking to support children in their lives?
So, you know, there are a number of organizations like Megan's and SolveME.org that are doing some great things. If you can, donate. We need to get research out there. And we are getting research out there, and that takes money. And also our advocacy work in Washington has been very productive. We, as an organization and affiliated with others, we were successful in getting $1.15 billion awarded to the NIH for research, which they're distributing slowly but gradually. That's not the only way to get this done. We need a lot more money, and it's not just going to come from government. As an employer, if you're an employer, I recommend you be sensitive to the fact that you have employees. If you have enough of them, if you have several dozen, I'm sure you have employees who have ME/CFS or long COVID, and they're hiding it from you, and they're trying to get by day to day. Maybe you want to try and, you know, get them out of the woods there, and reach out to your employees and ask your employees, does anybody have this problem? We want to work with you, and work with them. See if you can make them take some of their suffering away, trying to hide what they have. If you have friends who have this, do the same thing. Go out of your way to recognize that they have difficulty. Family members, the same thing. They don't want to burden you. You have to help them be part of your life because they are struggling to be part of your life.
Thank you so much, Stuart. And with seriously, applause. And with that rounds up a time we have today. Dr. Rowe, Megan, Stuart, Trevor, thank you all so much for a fascinating discussion and for sharing these intimate personal details of your story. We're so grateful for you spending time with the GIC and the Solve communities. We look forward to continuing our series on long COVID research, policy, and economic impact. We are very excited to share that the program series will continue in Victor, Idaho on Thursday, July 14th during the 14th annual Rocky Mountain Economic Summit. Registration is currently available on the GIC's website at www.interdependence.org if you'd like to check out that next series in the economic discussion about long COVID. Before we close, a replay of this executive briefing will be available on the GIC website and the Solve ME YouTube channels. I'd like to take a moment once again to thank David Kotok for his generous gift in funding and supporting this long COVID education program series. And as we conclude, I encourage you to take 30 seconds to respond to our audience survey that'll pop up. Your feedback is so important, letting us know how we can improve, how we can and appreciate the work that we do here for this various programming. Thank you once again for your attendance, for your time, for your attention. Have a wonderful day, and to the best to you on all of your health journeys. Thank you for joining us.